from National Taiwan University Hospital. First, I would like to thank the Glaucoma Society of the Taiwan Academy of Ophthalmology for inviting me here. In this talk, I would like to share how we manage advanced glaucoma patients in our hospital. All authors declare no conflict of interest for this study. This talk will be briefly divided into two parts. The first part, we will talk about structure and functional assessment in advanced glaucoma patients. Once functional damage affects the central 10 degrees of visual field, we cannot tell how's the preservation of macula unless we perform 10-2 visual field program. 10 degree and 24 degree visual field are both essential for detection of progression in advanced glaucoma. As you can detect the progression of inferior aqueous scotoma on 24 degree field, we can also find progression in inferior central part on 10 degree field. However, Humphrey GPA does not yet have a progression analysis using 10 degree fields. Rao and associates compared glaucoma progression on 24 degree and 10 degree fields. They found in advanced glaucoma patients, MD change calculated from 10 degree fields is significantly greater than the rate change from 24 degree fields. This trend is even more prominent in severe glaucoma patients. 10 degree field provides better estimation of progression in advanced glaucoma patients. In addition to monitor visual field progression, it's also challenging to find structural parameter for progression. This table estimates the measurement floors of different structural parameters. As you can see, the floor of GCC exists when MD gets around -13, followed by RNFL floor with MD around -17, then circumpapillary capillary density with MD around -19. The perifoveal superficial vessel density shows the lowest floor with MD around -25. This is a case of advanced glaucoma with prominent loss of RNFL and GCC at the baseline visit. Although we cannot see any change from the RNFL and GCC exam during follow-up, we can see a decrease of circumpapillary capillary vessel density over superior temporal quadrant. The vessel density change provides better estimation of progression in this case. Similarly, you can also see the decrease of superficial macular vessel density in this case. Macular vessel density may also provide better judgment of progression in advanced glaucoma patient. Visual acuity in advanced glaucoma patient can be highly variable, even if patients have the same RNFL or GCC thickness in glaucoma patient. In previous literature, we know visual acuity is strongly related to foveal ratio and the visual field sensitivity in the central area of the 10 degree field. However, it does not correlate well to structural parameter. In our clinical practice, we found macular vessel density show better correlation with visual acuity in advanced glaucoma and would be a promising structural parameter. Case 1 present with significant decreased superficial macular vessel density and well-preserved deep macular vessel density. The patient still have 20/20 vision. And case 2, the patient present with prolonged superficial macular vessel density loss compared to case 1. The deep macular vessel density was also affected, but was relatively preserved at the central grids. The patient has 20/32 vision. And case 3, the patient had more severe loss of both superficial and the deep macular vessel density. The patient has 20/2000 vision. And next, we will talk visual rehabilitation for advanced glaucoma patient. First of all, when we approach the patient, we need to have a detailed functional history taking on his visual complaints and the activity of daily living. For example, what can we do if the patient complains of unable to read newspaper? We will try to give him a good suggestion of magnification. We need to determine magnification needed as calculating the visual ability divided by visual goal. So, for a patient with 4M acuity wants to see 1M newsprint, we will give him 4x magnification. And this is the example of different size of Chinese characters converted from point size to M notation. We need to know what's the patient's visual goal and how we should recommend it. These are some near and distant devices for magnifying the object. We can give the suggestion based on different magnification needed. Then we'll talk about glare disability, which is a common annoying condition in advanced glaucoma patients. In our clinical practice, we found macula damage is associated with glare disability in advanced glaucoma. These two patients had a similar severe mean deviation on 24-degree fields. The patient presented with glare shows severe macula damage with defect on 10-degree field and the loss of superficial macular vessel density. The patient denied glare show preserved 10-degree field and superficial macular vessel density. We can provide different spectrum of filtered glasses to decrease glare. The patient can select preferred filtered glasses to reduce the glare issue. Recently, using virtual reality spectacles to expand peripheral vision has also been proposed in visual rehab for advanced glaucoma patients. As you can see, the imagery can be remapped to fit the residual field, which enables the patient utilize the residual field to see objects and enhance the mobility. This is the criteria for disability of visual impairment in Taiwan. By definition, once the patient with visual acuity or visual field fulfill the criteria, they can have the certificate for disability and apply for the subsidy. In Taiwan, there is a subsidy for low vision aids for certificate disabled patients. Every 2 years, each patient is available to apply for a low vision aid for 4 items. The clinician can help the patients apply for the subsidy with recommended of specific devices for functional needs. Sometimes we also need to communicate with the assistive device centers and apply for the CCTV. This flowchart briefly summarizes the system. Management of patients with advanced glaucoma. In this talk, we know in advanced glaucoma, circumpapillary capillary density and the macular vessel density may provide better estimation of glaucoma progression than current structural GPA analysis. Macular damage is associated with decline of central visual function and the increase of glare in advanced glaucoma patients. Macular vessel density and the 10-degree field can be robust tools for structural function assessment. Visual rehab is essential for the functional improvement and enhance the quality of life in advanced glaucoma patients. In Taiwan, a well connection between assistive device center and the clinician may strengthen the social welfare system for this patient. Thanks for